Hey guys, welcome back to my channel. Hope you've been well. I've been a little under the weather, but I'm back again with full force. Today we're here to talk about contraception, guys, ladies, young women out there, mothers. So today we're going to talk about contraception. It's a very, very big topic and a heavy topic and an important one because it's part of taking care of our reproductive health and taking charge of our own reproductive health and not leaving it in someone's hand. But before I start, I'm going to let Dr. Sule introduce herself again.
Hi, my name is Dr. Christina Sule, and I'm a consultant obstetrician and a general and cosmetic gynecologist at Alora Medical Practice, my private practice. And thank you, Catherine, so much for having me again.
Okay. So we'll start with what contraception is from Dr. Ari's perspective. For me, if you ask me, a mother of 7 children, I'd say just do not have children. But that's just not the truth. Let us say what contraception really is in medical terms and what it entails. The definition.
So contraception in very simple terms is prevention of pregnancy. That's all we're trying to do.
No more babies.
We're trying to prevent pregnancy.
Unwanted, unplanned.
Unplanned. We call it unplanned.
Not unwanted,
yes,
unplanned, guys.
Unplanned pregnancy.
Yeah, so I'm a bit biased. Unplanned pregnancy.
Unplanned pregnancy.
Yes.
And so that's basically what it does. And ideally what happens when you decide to have contraception, what should happen is that you should visit your gynecologist and they should do something called contraception counseling. And so that's basically a process through which they take you through all the methods of contraception that are available. They assess something called the medical eligibility criteria, which is basically to see, do you have any prior medical illness or condition that could make you a poor candidate for a particular form of contraception. So for example, are you diabetic maybe? Are you hypertensive? Do you have HIV? And then from there, they will choose a good contraceptive method for you and your partner. Rather, you and your partner will choose, and then they will let you know whether it works or not for you. They should be able to tell you the benefits. They should be able to tell you the side effects of that particular form of contraception. Exactly. And they should be able to tell you the non-contraceptive benefits. And that's where I usually like to spend a lot of time, because when you're getting contraception, you need to get value for your money. So not only should that form of contraception give you contraception, but it should give you some non-contraceptive benefits as well. And of course, the process is, a trial and error process sometimes.
Yes, like everything else in life. Like, for example, my own experience when I was dating Mike and, it was a blended family, he's going through divorce, so there's no chance here of me popping up a kid, before we plan, like you said. So I went for a contraception method and it was the no planned. And to be honest, I'll be very honest, the doctor explained everything like you said. A bit of that pre-counseling, maybe I didn't know the name, what it's called then, but now I get what it means. And because you were so afraid, I didn't want anything that doesn't have a high chance of, like, the highest chance of protection. So I was thinking, okay, fine, there's condoms, fine, which is guaranteed. Then we have natural ways, which we're going to speak about. Then we have popping pills. And I was like, what is a bit more, the chances are that it may not happen. Then we both of us had an agreed on Mirena, but for me, the side effects, like you said, were really not suitable for me. High blood pressure, adding of weight. And the good thing is that was 6 months when I came for checkup, because I came 3 months and 6 months, she was like, let's remove this type of contraceptive is not working for you. So like you said, trial and error in life. So again, women, there's no guarantees. Life is trying and finding out, and as long as you work with your doctor and you're able to report everything, I think everything will be fine. Okay, guys, so that's just my experience in terms of what the doctor is saying, pre-counseling. I think that's very important. And like she's saying, when you're informed, information, knowledge is power, and knowing what you're supposed to get. Don't walk into a doctor's room and they dictate for you.
Yes.
The contraceptive.
I agree completely.
Don't leave the room until you've discussed everything, asked all questions, put scenarios in front of your doctor. It's an experienced doctor. She knows what she's doing, or he knows what, I'm used to doctor, so he knows what he's doing. So feel free, ask all the questions before you get yourself into something.
Sure.
So now Dr. is going to talk about the different types of contraception, and I've learned a lot of things today, so she'll start with the first basic one as you go along.
Yeah. So the most basic form of contraception is natural contraception. And this is a method that is taken up by some people. Sometimes it's for religious purposes.
Yes.
Sometimes it's women who have a very heavy medical background of diseases that now just does not allow them to take up a lot of contraception. So it is, let me not say it's unpopular, it is used. And some of the methods that are available in natural contraception is like the withdrawal method, safe days, for example. There's one where we check, we try to estimate the time at which you're ovulating. It's called the symptothermal method. So your basal body temperature increases during the time you're ovulating. And so that can tell us, you know, if you're ovulating or not, and whether it's a good time to have sexual intercourse or not if you're trying to prevent pregnancy. We also have the cervical mucus method, where women observe their cervical mucus, and depending on whether it's too thick or too thin, they'll be able to tell whether it's a safe day to be able to have sexual intercourse or not. We also have something called the lactational amenorrhea method, which is when women are breastfeeding. For the 6 months that they are breastfeeding initially, they are considered to be protected against pregnancy, but it has very many conditions in terms of you need to be exclusively breastfeeding.
Yes, exclusively
You
breastfeeding.
need to be having 6 to 7 feeds for your baby a day. So not adding anything, no
It's work.
formula, no water, nothing. Yes, it's very strict. Yeah. So 6 to 7 feeds a day, exclusively breastfeeding. You've never had a period. It only works the first 6 months or so. And so if you can meet all those criteria, then it can,
be a
potentially,
candidate.
yes, it can potentially work for you. And I'd also like to mention that the failure rate of natural contraception is between 2 and 25%. So yes, 2 and 25%, and that's what most studies show. And so really it is up to you if that's a method you feel you want to take up. Yeah.
Being a scientist, 80% or 95%. Anyway, what you've just mentioned is very eye-opening, because now it makes sense why when you give birth, the doctor says, see me after 6 months. Because now the lactation thing now makes sense. I talk about the app, the way you're saying that, knowing your cycle. Some people, their menstrual cycle is not very regular.
Yes.
So if you're that type of person where your menstrual cycle that comes every 3 months, every 2 months is off, then again, you might not be able to get it right.
Exactly.
You get, so like you're saying, condition, know yourself,
Yes.
know what can work for me or not.
And it's actually good that you've mentioned that, because one of the reasons why natural contraception fails is because of misapplication. First of all, you're not doing the exact thing that you are told to do, but also the inability to predict when we ovulate and the inability to predict our cycles. Even women with very regular cycles, sometimes it's off a day, 2, 3, even 4 days, and that sometimes can bring about the failure of natural contraception.
I get it. And I know that in the world of today we have apps. Trust me, I do not have an app. I'm very old-fashioned. I cannot be there on the calendar waiting on a date. But I know there are people who, to be honest, when their periods come, they're able to tell their moods change. The symptoms are very evident. Your moods change. You get bloated. You get appetite. You have cravings. If you're not that kind of a person, then, which is me, you might just not. You know, and it's not heavy flow and stuff like that. So that's what I'm saying. For me, a natural contraceptive, we live to 7 more children and we'll be a football team, an official football team with backbenchers. They're called what? The pool were the substitutes, yeah. Another thing also, the ovulation one. Sometimes there are people who ovulate, there are ladies who ovulate, and the symptoms are not as evident. So that's something else to consider. So know yourself, understand your body, then you're able to make the decision.
Yeah.
I'm using myself as an example because that's what I have. And I know I'm not speaking for everyone. So like the Shari said, there are many reasons why women choose contraceptives. Yeah. It could be religious. It could be due to a condition. So to each their own. Yeah. So the next method, Dr. Natural contraceptive, second one?
We have non-hormonal methods.
Okay.
So the non-hormonal methods, some of them are like the condom, which if used correctly and consistently, can be 99% effective.
Okay.
And this includes both the male and the female condom.
Yes.
And then we have a diaphragm.
Yes, I've seen it.
Now the diaphragm, the problem with the diaphragm is that it has to be fitted by your gynecologist. Yeah, so it's not a very popular method. In fact, you probably, if you ever wanted one, you have your gynecologist dissuade you, because most people don't do it. It was used a fairly long time ago, still done in the States and in other countries. But yes, it has to be fitted by your gynecologist, and it is a non-hormonal method.
Okay.
And then we have the copper IUCD, which is the intrauterine contraceptive device. We have an copper IUCD, and then we also have an IUB, which is an intrauterine ball device. Now, the intrauterine ball device is like a string of beads with a longer string, and then it's inserted into the uterus, and it causes contraception. And the interesting thing about intrauterine devices is that they were first discovered by Arabs because they'd had to travel for very many months with their camels. And so what they do is they put a stone inside the uterus of the camel, and then the camel wouldn't get pregnant. And so that's how human beings evolved and decided, okay, what if we put something inside the uterus of a woman? Maybe that would prevent her from getting pregnant. Size, not a stone. And so, of course, that's when intrauterine contraceptive devices were developed. And so the copper one, I have one here.
Yeah, so that's the one we call a coil.
Yes.
That's the one that sometimes the kid comes cutting out. I'm joking. So joke people say cutting out like this.
So this is basically what it looks like. And I like to show this because sometimes when women see them, they just have like such a horrible idea in their head of what it is. But it's very tiny.
It's a tiny little thing. I've seen it, guys. I am in the business of planning.
So this is how big it is.
Yeah, it's this, and that's
this
why
is all for insertion.
Yeah, so this is for ease of removal. Sorry, I'm taking Dr. Tati's job. It's because I've been there, done it. And this is the coil. That's why it's called a coil. You can see the copper there. So
and
is this the famous
copper T?
Yeah, is this the famous copper T?
This is the famous copper T. It's shaped like a T, and that's the reason. And it has copper wound. This is the stem, and these are the arms. And how it works is basically that the copper ions are released from the metal itself, and those are toxic to sperm. At the same time, the coil itself sits at the very top of the uterus, which is where implantation happens. So now there's a foreign body at the point where implantation should happen. The other thing is that it also changes the cervical mucus, so it makes it much thicker. Yes, it makes it much thicker.
Not conducive for
sperm. Sperms are not able now to penetrate freely. Yes. So ovulation might happen, fertilization might happen, but at least implantation may not happen. Yes. And so this lasts for about 10 years. You can take it out at any point when you're ready to get pregnant. The good thing about it is that it's completely non-hormonal. So you're not going to get any weight gain, you're not going to get any acne or any of the hormonal effects, which I'll get into later. So when you have this and you come and say you've gained weight, I know it's not the coil. I know it's not the coil, right?
Yeah, and what about, sorry for interrupting.
It's okay.
What about this I don't know if it's a misconception, I'm not experiencing it, but there are women who say that, the copper T, I have a lot of infections with it, I have a lot of back pain. Are those some of the side effects with the copper T?
So some of the side effects that you can experience is an increase in your menstrual period. It can become either heavier or longer or both. So you might find you're having more days of your menstrual period, or you're using more menstrual product, or both. Yeah. Some women, of course, it's completely unchanged. The same way they had their period is the same way they have it now with the copper IUD. Some women can get something called intermenstrual spotting, which is in between periods they get a little bit of a bleed. And of course, as I mentioned, your cervical mucus will change, so you'll find the consistency of your discharge is much thicker. Now, in terms of infection, a coil itself does not put you at risk of infection. However, if you did have a coil and you developed an infection, your symptoms might be a bit worse because now there's a foreign body and an infection. But the IUD on its own does not predispose you to infection. Yeah, so the possibility of you getting an infection who doesn't have an IUD and me who has an IUD is completely equal.
Yeah. Okay, guys. So at least there's some misconception with a myth we've busted over there. So that's non-hormonal.
Those are non-hormonal. Of course, there's more, but those are the main ones.
These are the main ones. Yes. It's also available in Kenya.
Yes, it's available in Kenya in most clinics, including government clinics. Yeah, it's very popular there. And I must mention that the failure rate is 0.8%. So it's a very good form of
and
contraception.
Now we are talking 0.8% is near. And this also something else, a misconception that it has moved.
That's actually not a misconception. An IUCD can migrate. It can migrate, yeah. It can shift a little bit. Now, with the copper IUD, that can be very sensitive because it has to be in the right place. So what happens is sometimes when you get these symptoms like a bit of spotting or cramping, what your gynecologist may want to do is to do an ultrasound just to ensure that your coil is still in the right place. For copper IUD, once it shifts, especially if it's shifted really low and now it's almost in your cervix, it must be replaced. Because if it's not replaced, then your chances of getting pregnant are much higher. It can occasionally and rarely move even out of the uterus, which means it can be expelled out of the cervix and vagina, or it can move further into the abdomen. That can happen. It's very common, especially in people who have had it longer than 10 years, and sometimes they say, I think I had something like that.
Really?
And then, yes, when you do an x-ray, you find it somewhere next to the intestine, so it can migrate. So what I usually advise my patients is just to have regular ultrasounds to ensure, yes, about annually, to ensure that it's in the correct position.
Like Kathy, every 3 months, like go in there and see, is it the correct position? Please, doctor, because if it's moving, me and you are raising this baby.
Once a year is enough.
You don't make sense like Kathy.
Yeah, so it can migrate, yes, and that is one of the effects.
Good. So these are the questions that women normally ask, and these are the conversations we have in our circles as women, and someone throws a comment, so it's good to confirm it from a gynecologist perspective. Okay, so there's the IUD and the other one, the IUB.
Yes, IUB.
Okay, and then that is non-hormonal.
Non-hormonal, yes. Condoms,
what else?
A diaphragm. Yes, those are the ones. Those are major non-hormonal ones.
And then now we go to hormonal ones.
Yes. So we have hormonal ones, and hormonal contraceptives are very many. The first one I'd like to talk about is the combined oral contraceptive pill, and combined means it has both estrogen and progesterone, and it has that in very small amounts. Yeah. So previously, when they used to make them, they used to have them in high amounts, but they realized that the side effects were very high. So basically, what they started doing is to decrease both the amount of estrogen and progesterone to a certain level where it can still cause contraception, but cause minimal effects. And so this is a pill that generally has to be taken daily. It's taken for 21 days. Ideally, you should have a break of 7 days to have your period, and then you start a new packet. Now, the failure rate with typical use of oral contraceptives is about 7%. Right? So it has a 7% failure rate.
I like the 0.8, but
yes, but the good thing about it is that it has very many non-contraceptive benefits. So for example, ladies who have painful menstruation, sometimes it's treatment for that. Women who have irregular cycles, sometimes it can be treatment for that. So not only is it providing contraception, but also it's giving you a bit of benefit on the other side. If you had a painful period, now you don't. It was initially irregular, now it isn't. So those are some of the, and it's also used to treat acne, by the way. So if you have acne and you're looking for contraception, yes, you might want to try as a contraceptive method. And some of the side effects of the combined oral contraceptive pill is that it can cause weight gain, it can cause headache, it can put you at a slightly higher risk of breast and uterine cancer, but it's protective against ovarian cancer. Right? Again, if used over 5 years, it can put you at a slightly higher risk of cervical cancer as well. Right?
Cervical cancer is a big one.
Yes, it can put you at a slightly higher risk, especially if used over 5 years. One of the other effects is that you can develop a clot. Now, this is a bit of a controversial issue because high-level studies have shown that it does not give you deep venous thrombosis, which is a clot in your lower limbs. But low-level studies have shown that it has, and so you can't completely ignore. So it's a bit of a controversial issue. It's a possibility.
It's a possibility. Yes. And you have to be aware of what you're getting yourself into.
Yeah.
I think the next one is the famous Depot. We call it Depot. That's what we used to call it.
Yeah. So Depot is very interesting because it's progesterone. It's progesterone only.
Injection?
Yes, it's the injection. It's a 3-monthly or a 2-monthly injection. It's actually been discontinued in some countries.
I know it was even banned, I think, in the States.
Yes.
But there's a time we used to get it, and here it was a 6
It's still
month.
given.
It's a 6-month injection.
It's a 3-month injection.
Why? You see? What?
3 or 2.
Okay.
It can be 3 or 2. And the thing is that it causes contraception by it's like a small dose of progesterone. And what progesterone does is that it makes the lining of the uterus very thin. Sometimes it can make it disappear, which is why sometimes women on depot can have no period at all, or they can have a bit of erratic bleeding. Sometimes the period disappears for a while, then it comes back, lasts for many days, goes away, comes for a short time, very erratic. That's one of the side effects. But basically it works to prevent ovulation from happening, but also make the lining of the uterus very thin. Now, one of the interesting things about depot, which is not necessarily a good thing, is that when it's used in young girls, it can predispose them to osteoporosis. So they'll be more exposed to weaker bones and fractures, which is maybe one of the reasons why it has been discontinued in some countries, but it's actually still given in Kenya, especially in rural areas, and it's an effective contraceptive.
No, it is an effective contraceptive. And I've seen, I've had many conversations with women where they say, depot doesn't make me add weight, it makes me lose weight. So some women are like, it helps me control my weight. So like you said, you had it too. So every woman's body is different, and how you'll react to a contraceptive is not the same. So instead of having conversations over chama about a contraceptive, it's good to have, but do not consult over chama, unless you have a specialist. You don't have contraceptive conversation over tea and wine, man. Because someone else's experience is not yours. So kindly seek professional help. And I will insist again, like Dr. Shaya has insisted, frequent checkups. Okay, then depot, what else?
Another thing about depot is that it can be used when you're breastfeeding, because it's progesterone. It doesn't have estrogen. So unlike the combined oral contraceptive, and some of the ones in Kenya we have are like Yasmin, Microgynon, those cannot be used during breastfeeding. But during breastfeeding, we can use progesterone-based contraceptives, which is like depot and others. So that's another thing about depot.
Okay. What's our next one? I'm waiting for my favorite one. What's your next one?
So my next one is Implanon.
You're not my favorite.
No, Implanon is a lot like the Norplant that you had, but it's a more modified version of that. It has a 99% effectiveness against pregnancy. And
99, you see what I was going for?
Yes, and basically it's a small silicone-looking like stick that's placed in your upper arm, preferably on your left arm. It's placed under local anesthesia. It's very tiny, so you get a small injection of local anesthetic, and then you get the Implanon. It has an insert I'm going to show you right now. And what it does is that it works for 3 years, and it releases small amounts of progesterone into your bloodstream at a regulated amount. So the effects of Implanon are usually much less than depot. Depot is like a slightly larger dose. Implanon is small doses over 3 years. Again, you can take it out at any point you want to get pregnant, and ideally you should be able to get pregnant more or less immediately. It can cause effects like weight gain. Some women, it gives them weight loss. It causes some of the things it can cause is acne, low libido, vaginal dryness, headaches. Yes, those are some of the effects that you can get with the Implanon.
The weight gain, it was real.
And again, the progesterone works to thin out the lining of the uterus. So again, you can have no period while on the Implanon for like 3 years, or you can have some form of erratic bleeding, or your cycle can remain exactly the way it was. And unfortunately, with contraception, we can't know which effect you're going to get, how many you'll get, how they'll come until you try it.
Exactly. Yes. So that's I remember it like yesterday. Like I think it's still there. So that's the what is called Norplant. I call it Norplant, guys. This is a street lingo.
Yeah, I'll just show it inside here. This is the inserter, and this makes things so much easier. It's just like one small prick, and it's loaded inside this metallic little piece. It's loaded like a thin little silicone stick, and so we just press this button, it goes under your skin, and that's it until the day of removal. Yes.
And for women who they don't get their period those 3 months, most women have said that once they remove it, their periods do come back, and they're able to give birth. So that misconception that contraceptives can make you have conception issues or fertility issues. Is it true?
It's not true, and it's been proven by many studies. People are usually very vocal about that with the e-pill and with the combined oral contraceptives. Sometimes it can make you miss your periods for a while. After, we have something called post-pill amenorrhea, where a pill can make you kind of miss your periods for a while, but ideally they should come back, and it does not they do not cause issues with fertility. Including the e-pill.
Including the e-pill.
Yes.
Hey guys, research has it, and again, research is the only thing we can depend on. But then again, we're evolving, and obviously, as it's getting updated, they will definitely try to use the best available method, because we are in a developing country.
Yes.
So we're in a developing country, so sometimes we might not have too much variety.
Yeah.
So they're doing the best they can with what they have. And I think our doctors are very experienced. I don't think I know. They study a lot. I was with them in campus doing biochemistry. That's why I quit in the middle. So they are very informed, and there are services that I don't really think we need to go outside of the country for. They're here available, and let's trust our doctors. Do research for yourself. And give them a chance. Yeah. What is the next contraceptive?
The next one is the progesterone-only pill.
When are you getting to mine?
The progesterone-only pill is a pill that has only progesterone. We like to give it to women who are breastfeeding.
Okay.
Especially from the time their babies are 6 weeks. Ideally, you have a consult with your doctor 6 weeks after delivery, and that's the point at which they should be introducing contraception to you and doing this kind of counseling. If you've previously had contraception and you want to continue with the same method, that's fine, as long as it doesn't have estrogen. But sometimes women can't decide what contraception they want immediately after delivery. So that's a good time for them to have the pill, to think about it. Exactly. To talk to their partner and see, what works for them at that point. So we can give it to women who breastfeed, and it works exactly like the implant, exactly like the depot, with the exact same effects.
Yeah. And again, you say progesterone when you're breastfeeding is not harmful, because there's no estrogen.
Yes.
Okay. Yes. Next.
The next one is your favorite, the hormonal IUD. So this is the levonorgestrel IUCD, or levonorgestrel intrauterine contraceptive device. There's very many companies that produce it. It has very many names, but in Kenya, the most popular one is Mirena. We don't have a paid partnership with them, but I will show you what it is.
People
because
just
it's what I use.
Mirena.
Because it's what I use in my clinic, so everybody calls it Mirena. That's what it's called. And basically what it is, it's a hormone-releasing IUCD. And what it does is that it releases small amounts of progesterone over a period of 5 years. And what that does, again, is to stop ovulation from happening. But more importantly, again, making the lining of the uterus very thin, so that if for some reason fertilization happens, then there's nowhere to implant. There's nowhere to implant. And so the good thing about Mirena is that it's 99.99% effective.
You see?
Yeah. So now we have a 0.1% failure rate. And other than the 0.1% failure rate, it has a lot of non-contraceptive benefits. True. So ladies who have very painful menstrual periods, ladies who have mild endometriosis, it can treat that, exactly, because it makes the lining of the uterus, or the endometrium, shrink. So not only does it shrink in the uterus, but even the ones that have escaped out of the uterus will begin to shrink, as long as it's not moderate to severe. If it's mild, it can treat that. If some women who have small uterine fibroids, it can make them shrink as well, as long as they're not too many and not too big. It has been recognized as one of the treatments for small uterine fibroids. So that's another benefit. And of course, the very high efficacy rate. So, and a large number of non-contraceptive benefits and a very, high efficacy rate.
You see, I've moved from 0.8 to 0.1, guys. But also, I think, to mention, like, sometimes everyone's side effects are different. Your periods might go away, it might become lighter, some back pains. But I like the efficacy of Mirena, and that just to show you, like, it's plastic.
It is. And I like to show this so that we can conceptualize and so that we can bust some myths. So everything from here to here is the insertion. It just helps me to insert
it's not this big,
but the IUD is this small. So it's just as small as the copper one that I had shown, but then now this is more of a plastic or silicone feel. It's literally this small. Of course, insertion can be a bit uncomfortable, and you can have a bit of cramping and spotting, but ideally it will make the period much lighter, much less painful, and the spotting usually persists for about 6 months. After 6 months, it goes away. And if the effects are too strong and the spotting is too much and the cramping is too much, way six months and beyond, then of course you can have it removed
and try something else. So that's Mirena, guys. I like, again, the efficacy rate, and again, I will repeat, frequent doctor visits. We cannot afford to have it moving, and just to ensure that everything is okay around that area. Is there any other hormonal contraception?
Yes, we have the hormonal ring, which is similar to a diaphragm, but it's like a ring that has a hormone that's placed around the cervix. And so it just makes that area very harsh in terms of, sperm permeability, in terms of, conception. So there's a hormonal ring, not very popular. And then there's also the patch.
Oh, yeah.
There's also the patch that you can place. For me, the reason why I don't really like the patch is because this is for me in particular. This is not maybe any other gynecologist. But for my patients, it's had a high failure rate.
Oh, okay.
For my patients. And then the other thing is that if you have a skin reaction, then it's not absorbed as well as it should be. It can have a failure rate just because you had a skin reaction to it. Sometimes it can fall off inadvertently and you didn't know because the adhesive maybe wears out before the time had come. And of course, during those days, you can get pregnant. So that's another way of, that's another form of contraception.
So I wanted to ask, what's in the patch? Is it progesterone, estrogen, or?
It's both estrogen and progesterone.
So like the pill,
like
but now it's being released through the patch,
pill,
like the combined pill. See, a good memory, good student.
Yes.
Okay. That is the end of hormonal contraceptives.
Yes.
Okay.
Yes.
And then we go to the final complete. Prevention of pregnancy, where there are many methods you could mention today, because there are some people who don't want to do those other contraceptives we talked about, and they want something else. So what are the other permanent contraceptive methods that we have?
So we have permanent contraception for those who have completed their childbearing and are very sure. So one of them is bilateral tubal ligation, which is where your doctor will generally tie your fallopian tubes, cut and tie your fallopian tubes, and this is permanent. The good thing is that ideally it has about a 99% effectiveness.
Like
however, however, there are some patients who can get pregnant. We have something called recanalization, where the tube grows back together. It's very, very rare, but it can happen. It's extremely rare, but it can happen. It can happen. But it's more or less a permanent form of contraception. And previously, there were some issues legally because women, needed consent from their spouses.
Yes. And
had to have a particular number of children before they can do it. Yes.
Like
and
it was
be
above
a particular
35.
age.
Was it above 35?
Yes. But right now, we don't have any of such issues.
Good.
As long as there's informed consent with an adult of sound mind.
Sound mind, because sound mind is something else, because you could be coming from a place of emotions, your trauma, post-traumatic syndrome, what is it called?
Stress disorder.
Post-traumatic stress disorder, postpartum depression. So sometimes you make that decision very quickly and then you might regret it later. But you said it's not reversible.
So now it is reversible, but with very, very poor success rates. And if you do reverse it, it does predispose you to an ectopic pregnancy because that tube was previously cut, now has been rejoined. So you're very likely to get an ectopic pregnancy. So be very, very sure when you have a tubal ligation. It can be done maybe during your cesarean section if you've had one. It can
and you've
be
signed
done,
the consent.
Yes. It can be done laparoscopically at a later date. So through minimal access surgery, it can be done in that way as well.
So tubal ligation.
So tubal ligation. Vasectomy is another, of course, not for women, but for men.
For men, yes, vasectomy for men. Yes, please talk about it.
It's a more permanent form of contraception. Of course, there is a bit of reluctancy, especially with African culture. Yes, but it is a more permanent form of contraception. If you, as a couple, decide that this is what your partner is happy to do for you, then that's another way of having contraception.
And it's not to be honest, I feel it's very caring and empathetic, because you then, me as a woman, spare me all those hormonal contraceptives. And also I know that sometimes as we get older, I have menopause and stuff and dryness and all those things. So to be very, if our men could embrace it more, we've agreed and we have enough kids. But also I wanted to bust this myth that men say, I'm being castrated. You're not being castrated. And here is a doctor today.
Yeah, that's the truth. It does not have any effect on libido. It does have its own side effect, which if ideally you're having it done, your urologist is going to explain to you. But loss of libido is not one of them. So it's not a castration. Castration is removal of the testicles.
Thank you.
This is different. This is, we're basically interrupting the conduction of sperm outside the body.
Exactly.
Yes.
So people, it's not castration, and let's not stigmatize it. And also, I think for us, women need to take charge in terms of this is a partnership. Yeah, when this child comes, it's both of us. Yeah. So I think thank you for busting that myth, and I know that it's mostly common with the white descent
In the
and
West.
in the West
Yes.
and the Indians, but Kenyans, Africans now are more
More open to
more
it.
open to
That's
it,
true.
as long as you explain to them. So that's also another option, vasectomy.
Yes. Yeah.
And it's not castration. What
Yeah.
else? Triple ligation vasectomy.
Another option is removal of the uterus altogether, which is a hysterectomy. And some women choose to go through that, especially maybe if they've had very problematic fibroids along their reproductive career, or if they've had maybe several abnormal pap smears and there's no, permanent solution to that, they may decide to just
Remove
be
the
done with the
uterus.
uterus as well. And there are some women who choose to have a hysterectomy
They
even
never
without
want to have kids.
even
And,
without any of these
yeah,
issues.
I even
Yeah.
seen a documentary, but not in the West, where ladies who are between the age of 18 and 21 have removed their uterus.
Which is
and
unfortunate.
I think
A bit too
I
early,
think it's a bit too early. And I'm not trying to take away the fact that maybe at that point and your emotions are not valid, but I think it's a bit too early. Give it time. There are ways where you can buy time and decide.
Minds change.
And minds do change, and give yourself time to grow, develop, and test the world a bit. I think that's a bit too young, but anyway, people have done it. And is there a big side effect of removing your uterus? I hear them women speak about it, but I've never spoken to a guy about it. They say early menopause, dryness, brittleness of hair, brittle nails, dryness of your skin, and all those things. Is it true?
So yes and no.
Okay.
When you do a hysterectomy, you have two options. You can remove the uterus only, or you can remove the uterus and the ovaries.
Okay.
Now, for women who have the uterus and the ovaries removed, those are women who usually have abnormal pap smears, early stages of cervical cancer, and they don't want it to spread to the other organs. Yeah, or very, very problematic fibroids, and they are very close to menopause anyway. So we can just take out the uterus and also take out the ovaries. Now, for those women who are doing it for contraception, or maybe they, like say you're 30 years old and your fibroids are just terrible and you're just taking out your uterus only, you do not need to have your ovaries removed.
Okay.
So the ovaries can be left behind. Now, for those who do have their ovaries removed, yes, they do get vaginal dryness. They are basically woken up into a sudden menopause. So they do have vaginal dryness. They have hot flashes. They have insomnia. They have urinary incontinence. They have painful sexual intercourse. A very fragile and almost brittle vagina and vulva. So yes, they do get all those symptoms. Yeah.
And that reminds me, menopause is a topic we are going to talk one of these days, and we are going to have a guest on show, maybe one or two, because menopause manifests itself differently in women, the same way we say the effects of contraceptive, because I think we need to be informed. Knowledge is power. If you're getting to 50, it starts differently from everyone. I know people who started, or women who started at 45, others 55, but just know what to expect. You just can't live like that, and then menopause hits you like a bus. And that's what happens with time, and then you don't know how to deal with it, because I have seen many older women dealing with menopause, and I'm so informed, like I'm ready
to combat it.
I'm ready with all the information. Obviously never too ready, but I think it's a topic worth talking about, because it's something that happens to most women. I think
to happen to everyone.
I think to everyone. If I'm not, no, I didn't want to say everyone because I'm not a gynecologist, but I'm just thinking to most women, because it's a natural process. Okay, so that is it. Remove the uterus. Is there any other contraception that is permanent?
There's other permanent methods, but those are the more popular ones.
More popular ones. I guess we don't want to have a biology lesson and Dr. to whatever she learned for 10 years to talk about it today. It's already a long video as it is. I think also something else, Dr. is to talk about, maybe just mention, like you said, we have them in government hospitals. We also have private clinics, and that's not saying that government hospitals don't have qualified doctors. They are really very qualified doctors. It's the government enabling us to have options, so that every other woman, regardless of their economic status, where they are in the village, in arid areas, have access to contraceptives. So could you kindly give a range of, not every contraceptive, like the range of contraceptives in Kenya, from like 500 to what the highest, and then people know that it's not unreachable. Don't think about contraception and think, oh my god, I can't afford it, because you can walk into a government hospital. I remember Depo used to be 60 bob in the government during my time, a while back, I think in when I finished campus. So it's not something that's could you tell us the range, the basic?
So basically, in a government facility, what you will find, you'll find condoms, which in government facilities are actually given for free.
Even in campus.
Yes, over a very nominal fee.
No, even we talk about higher level educational institutions where you would find them in the bathroom. The funny thing is when they were being put, they were full, but then it becomes empty and you don't know who picked them. I don't know when they do pick them. So we used to joke and say, man, they'll be filled. And then it's empty. We're like, who took them anyway? But I think that was a very, very good step the government took. So we do have free condoms also in universities.
You get the condoms. You will get Depo.
Okay.
You'll get Implanon, actually.
Wow.
Yes, you'll get Implanon in government facilities. You'll get your copper IUD.
Wow.
You'll get your progesterone-only pills. You may get a combined oral contraceptive as well. Actually, probably the only thing you will not get is an intrauterine ball device and a Mirena.
Okay.
Yeah.
Which is quite steep. It's expensive. It's expensive.
Yeah.
Yeah. So any woman who's at home, any young lady developing, don't think that these things are not within your reach. And again,
they're affordable.
Yeah, they're affordable.
Yeah. So the condom is like, I mean, if you had to buy it yourself, not
3
sure,
packets.
is it like
packets.
How much? 3, 30, 50 bob? I'm not really sure.
We are all 50 bob. But big guys are telling me to young are like 50 bob, you know. And during a time, guys, this is about his secret.
Yeah.
You go to the chemist and you talk about 10 different things. I want before you narrow down to condoms, you know. But young people
and
now are more...
and in government facility, so basically your range of contraception in government facility can be anything between 50 bob and, let me call it, on the steeper side, 1,500.
You see?
Yeah.
And to be honest, people, we buy clothes, makeup, nails, hair, alcohol, coffee, you know, so it's something you can save and spare. And again, like we were saying, I think, I know as a woman that your reproductive health and contraception is your responsibility. You can't leave it to someone else. It's good, like you said, and it's very important to talk with your partner. Again, situations are different and we are not judging, but you need to take charge of your own reproductive health as a woman. And again, Dr. Ria said, please seek professional help. Okay? Google is our friend, but again, Google is not a doctor. You can just get a few points, but ensure to visit a professional. So we have government gynecologists.
Yes.
And maybe consultation is not expensive.
Actually, in government facilities, there are very well-trained nurses who actually administer the contraception.
Nice.
Yeah.
And I'm sure there are also very, very trained midwives who've given birth to thousands of children, and so they are very competent to give contraception. So ladies outside there's no reason for you to have unplanned pregnancies, not unwanted, unplanned pregnancies. We live in tough economic times, let's be honest. We need to plan for our children. We don't live in times where, for me, when in a government school, we were 5 of us and school fees per term was 1,000 shillings. If you're given that 1,000, you lost, you just know you're dead. It's a lot of money then. We have to take parenting seriously, be responsible. As the government is helping us, we help ourselves. As God is helping us, we help ourselves. And in a relationship, sometimes, most times, I think planning is very important with your partner, so that at least we are able to live a comfortable life and we know the limits of stretching ourselves financially. I know we have this famous saying that mtoto anakuja na sahani yake, but pia lazima tunajipanga. Anything else that you want to add before you finish?
No, that's it. I'd just basically say contraception is something that, again, trial and error. What works for me is not going to work for you. Very many patients come saying, oh, my sister had this and it didn't work for her. You're not your sister. And just see what works for you.
And that's the reason you have the doctor, to have a personalized plan for you. And again, they're here and they're learning also. You know, like researches and studies are being done every day. There are obviously outliers in the system, in life. So seek professional help, regular checkups, be informed, Google, go see a specialist. And again, it's our responsibilities as women. I hope you enjoyed this session. I know I'm trying to see how I can do a giveaway for someone. I'm sure. See, I always like doing these things because there's someone outside there who might not be able to afford to come to see Dr. Dr. might give you the consultation for free because of our relationship, but then I would like to pay for the contraceptive, you know. So I don't know how I'm going to do a giveaway, but I'll think about it. Maybe I'll do for two ladies, and then I can't dictate what
they're going to get.
What they're going to get, but I will cover the cost for you because it's the least I can do, and it's empowering another woman because I know they'll carry it forward to another girl somewhere, another woman somewhere. So my people are going to announce how you're going to win the giveaway, and I'll go see Daktari, and at least I'll know they're in safe hands. Thank you for coming, Daktari. And these are very important topics which sometimes we don't get to have it with our moms or aunties, and we get to have, like I said, our friends in the bathroom, in the club. 30 after morning pills, you know, and then mistakes do happen, and it's life. But it's good to be informed. So before we outro, I've just remembered emergency contraceptive, which is what we famously or street lingo call a morning after pill, or this, I don't know, which
e-pill.
The e-pill, and Dr. might give it a scientific name or a medical name, but please tell us instances to use the emergency contraceptive, because I know when we were younger and in campus, it was really abused, and it's something that it was spoken about, written in books, not to abuse emergency contraceptives.
So it is actually called the emergency contraceptive or morning after or e-pill, even medically. It
was 100 bubbles, it's expensive.
And so the thing is this, that yes, it is still misused, even the way it was previously. I'd like to mention that it is not a form of regular contraception. And for those who feel like they are having regular sexual intercourse, or they have a serious relationship
and a constant regular partner.
Yes. So basically what they need to do is not use the emergency pill. They need to have long-term contraception or something more more permanent, of course with use of condom. Condoms should always be used,
is a must.
Even with contraception,
because of
STIs
and
and HIV. So we should always use condoms.
That is a topic for another day. I'll never forget her exhaust. It's to scare us to death.
So condom use is very important to prevent STIs, HPV, HIV. But if you do use a condom and you want something long term, you can still have a long term form of contraception. Emergency pill, the name dictates emergency. Has an emergency happened? Yeah. Was there an emergency unprotected sexual intercourse?
This is
something
not
that was not planned for.
It's not advisable, but life does happen, and accidents do happen. But you said it's emergency.
Yes, emergency.
Sometimes
in a rape case, exactly, in a rape case. So it should be used as an emergency. Now, when used frequently, and sometimes even just a one-off use, it can interfere with our menstrual cycle. Because it contains either estrogen only, or a combination of estrogen and progesterone. Or another one that is available abroad is one that contains ulipristal acetate, which is another hormone. So there are 3 versions of it, but the hormone is in very high amount, so that pregnancy does not happen at that point in time. So imagine taking that high amount of hormone every time.
And is it true? So, it had to be within 24 hours.
So it has to be within 72 hours.
Hey, people used to run to the chemist.
Yes.
Yes. Those days, there was no Fuliza and Mshwari. You borrow actual debt.
So yes, within 72 hours, and the efficacy goes down within those 72 hours, right? So the earlier you take it, the better. If you're very close towards your 72 hours, the efficacy has now significantly dropped.
Imagine we used to think 24 hours, guys. We didn't have Google. So you see, again, we learned word of mouth. So we used to know 24 hours. So it's 72 hours, which gives you a window in terms of like rape, other emergencies.
Yes, exactly.
Yeah, sometimes date rape and stuff like that. So we're not here saying that life is perfect and everything can be planned. Accidents do happen. But then again, we are all here talking about informed engagement of sex at the right age, knowing your responsibility. So it's not this a decision you make with emotions. So that's why we are saying emergency contraceptive when accidents do happen, because life is not perfect.
There's one more form of emergency contraception, actually. The coil, the copper coil. So if you have unprotected intercourse, you can put in the IUCD as a form of emergency contraception within 5 days of
Within 5
unprotected
days.
sexual intercourse.
See?
Yes. So if you pass the 3-day limit, or maybe you took the e-pill very close to the 72 hours and you're still unsure, you can have an emergency. Only the copper T has been approved for emergency contraception within 5 days of unprotected sexual intercourse.
Okay.
Yeah. So there's one more
I'm calculating.
last option.
5 times 24, that is 120 hours. Yeah. Mathematical mind. So 120 hours, people. So I think that's it, and I hope you enjoyed. And until next time, guys, bye. And I'm sure we're going to do a live on this if they have more questions. Yeah.
Yes.
So until next time, guys, see you.
Bye.